Assalamu alaikum wa rahmatullahi wa barakatuh. So today we'll cover a very special topic. I really like it a lot actually. We try to cover it very fast. The whole acquired heart disease, from rheumatic fever, Kawasaki disease, and lastly infective endocarditis. Of course, we're talking about pediatrics. First, okay, let's start with rheumatic fever. Actually, these acquired heart disease, they can follow the group A streptococcus infection. What is it actually? Remember group A, which is streptococcus pyogenes, okay? And then we start by rheumatic fever. So rheumatic fever, what's rheumatic fever? It's acute rheumatic fever. It's non-suppurative, delayed autoimmune sequelae of pharyngitis and skin infection. So when we got this skin infection or this infection, okay, and then by streptococcus pyogenes, we will have activation of our T cell, B cell, like our usual immune response lymphocyte, by streptococcus antigen, the antigen that produced, we know this antigen of the streptococcus, right? We're gonna form antibody by B cell and T cell, and we have something special. Remember your immunology, super antigen, which is massive T cell activation and release of large amount of cytokines. This will cause something we call systemic toxicity in all over your body. So all over your body after this streptococcus infection, you will form something that we call it the antibody. This antibody start in your immune system, will have immunological cross reaction between strep M protein and heart muscle molecular mimicry. What do you mean by this? So the thing that we formed from streptococcus pyogen antibody, okay, it will look similar to the heart muscle cells. So our body will okay, this streptococcus has an antigen, okay, and the heart muscle has cells. These two, they will look like each other, they will look similar, like this. Maybe they will look similar, but they are different, of course. So our body recognizes it as the same, so we'll start attacking our own vessels, our own heart muscles, and so that what we call it molecular mimicry. It acts like the heart muscle, but it's not. This is a picture of pharyngitis. Tonsillitis by strep pharyngitis probably. So, and then you will have rheumatic fever. It will affect your heart, joints, skin, and CNS. We'll try to cover what will happen to your heart. As we said, antibody against M protein. The protein looks like similar to the some of the heart ones. So your body will start attacking your heart, will cause pancreatitis. What do we know by pancreatitis? Endocarditis, pericarditis, and myocarditis, all of them. You know, there's something special here in pathology. If you remember Ashkoff bodies, we see it in the myocardium. This Ashkoff bodies, you see? It's very clear in this picture. Ashkoff bodies. It's special in rheumatic fever, myocardium. And then what will happen if it affects your joint? This is if it affects your heart. What will happen if it affects your joint? You will have something very special also. We call it polyarthritis or migratory polyarthritis, where the pain for the patient will start like in his knees, but then later it will goes up to his joints upside, like his hip joint, something. So inflammation of multiple joint swelling. It will be red, warm, and painful. And migratory, this is the important thing I'm telling you about. Move from one joint to another. From large joint probably started, yes, and then goes to smaller joints. This is if it affects your joints. For your skin, we will have something characteristic of rheumatic fever. We call it erythema marginatum, which is ring, non-itchy, just scars. Not scars, sorry, rash. So it's not itchy. It's like similar to Lyme rash. If you know Lyme disease rash, it's similar, and it's not itchy, worse with heat. And why does it happen? Because our vessels, small vessels, it has inflammation, so it will start showing this rash. We have also subcutaneous nodules. Subcutaneous nodules are small. You can see them in this area, you can see. And let me zoom for you. This one. You can see it, right? This is subcutaneous nodules. If you see it, you can... It's very characteristic of rheumatic fever. It's... why does it happen? It's like, you know, your immune response and things, it will deposit in this area. So this is subcutaneous nodules, erythema marginatum. How about your CNS? If it affects your nervous system, you will have chorea, syndrome chorea, which is like this dancing movement, like this. Why does it happen in children? Because the antibody will cross the basal ganglia. And you know, this chorea, we see it also sometimes in other nervous system, like I don't want to say it because I'm not sure, but you can see it in other nervous system disease when it affects your basal ganglia. What was it? Oh, cerebral palsy. Yes, cerebral palsy. A special type of cerebral palsy. You can see chorea, and he's like dancing. Okay. Moving on, let's see the criteria. There's a diagnostic criteria of acute rheumatic fever, for initial one or recurrent one, but let's be generally. Okay, we call it Jones criteria. Jones criteria, you remember John... Oh no, I mean, remember John, not O, but heart, N-E-S, okay? Remember these three, there's a picture for it. G for joint. Joint we mean by joint arthritis. O we mean the heart, we mean pancreatitis. N nodules, subcutaneous nodules. E erythema marginatum. And S syndrome chorea. Okay, what is the criteria? The criteria says these are the major, we've just mentioned them, the Jones one. These are the major manifestation. And other minor manifestation like leukocytosis, increased raised C-reactive protein, fever, just simple arthralgia, not migratory arthralgia, but simple arthralgia, joint pain, previous rheumatic fever, first degree atrioventricular block, and leukocytosis. These are the minor criteria. And so now how many you need for major, how many you need for minor to diagnose. First, for major, let's say there's recurrent and initial. Let's move with initial one. 2 major manifestation and evidence of proceeding infection, or 1 major, 2 minor. So we need 2 major, or what we need, I did not write it down anywhere. Oh no, it's here. 2 major criteria is enough, or 1 major, 2 minor. This is enough for rheumatic fever. The patient doesn't have to show all these symptoms. That's what we mean by criteria. You want to diagnose rheumatic fever. The child presented to you, let's say, with only polyarthritis, let's say, and then it's happened to he had polyarthritis and he had fever, and he was diagnosed earlier with rheumatic fever, so you can diagnose him. This is 1 major, 2 minor. Let's say he presented with you with the rash and chorea. This is also enough, and fever. This is also enough for the criteria to be, so you can say it's rheumatic fever, fine. Okay, this is the least thing. Of course, if all of them, let's say they present also, this is typical. So what are investigation you're gonna do? Of course, full blood count, looking for leukocytosis, ESR, and C-reactive protein. There are the minor criteria. You do throat swab culture. Okay, let me follow with you. Here, throat swab or culture, and remember you have to do it before you give the antibiotic, because no point of the antibiotic, you will get a negative positive culture. And then antistreptolysin antibody, ASOT, it's elevated, it's markedly elevated antistreptolysin antibody. We can do this actually in a patient with Kawasaki disease because we want to rule out rheumatic fever. Okay, and just X-ray, you look for cardiomegaly, pulmonary hypertension. Very important to do ECG. Why? We just say that because there must be AV block. Not must be, there might be first degree heart block, prolonged PR, and echocardiography, of course. You look for cardiac dilation or any valve abnormalities, because you know that the rheumatic fever complications affect the valve. So that's why. Your management, of course, antimicrobial, primary penicillin, bed rest, and aspirin. Why do you give aspirin? Why do we give antiplatelet in this patient? So this is a point. We don't give aspirin as antiplatelet. When we give it in a high dose, aspirin will be antiplatelet, but in low dose, it will be anti-inflammatory. So that's why we give aspirin. Um, Corticosteroids, and we rarely need surgical movement, only, yes, as I said, complication like mitral regurgitation, mitral or arterial stenosis, like this. And aortic stenosis we see only if it's severe. Of course, you give primary prophylaxis treatment when the patient child has strep pharyngitis. It's very clear you're afraid his immune system is not that good, he doesn't look okay, so you can give prophylaxis. You know that you have it's one of the differential of rheumatic fever is systemic lupus and juvenile rheumatic arthritis. So you must do the test to rule them out. It's better. You're a professional doctor. You act like that. Okay? You have to think always. So we move on to Kawasaki disease next.